the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Listeners, welcome back. Today, Chuck Dowell is back on with us. Chuck is a PA and sees a wide variety of patients in clinic, and today we're going to chat about one of his cases. Chuck, welcome back, and I hope you might tell our listeners about someone with an elbow issue.
Hey, yeah, thanks for having me back on the podcast. Yeah, I think Olecranon bursitis, or kind of swelling of the elbow, is definitely a common thing we all see in clinics, and there's a little bit of uncertainty of how to treat it. Should we aspirate it? Should we not aspirate it? Kind of what do we do with this? So I thought it was a good case to go over. So one of my typical presentations, I had a 45-year-old male come to clinic. He had the acute onset of a fluid collection within his elbow, went to sleep, maybe had some irritation to the elbow, woke up and had this fluid collection right over his olecranon process. No trauma to the area. He did a workout the day before with a little bit of triceps, but nothing significant that he doesn't normally do. No overlying abrasions or scabs, no redness, no concerns for, an injury to the area. Examination of the elbow showed that he had a moderate fluid collection within that Olecranon bursa. Full range of motion in the elbow. Range of motion was not painful, had normal strength with pushing and pulling. No overlying signs of infection in the skin, no erythema, no edema, no scabs or, concerns for some wound to the area. X-rays of the elbow did show the olecranon bursal fluid collection. A small little osteophyte was seen at the tip of the olecranon, which could kind of represent that tractional osteophyte from the triceps, but otherwise normal appearing X-rays.
So, Chuck, you mentioned this already, but what is going on with this patient?
So, in my differential, I would say olecranon bursitis is definitely a differential. You could consider a triceps tear. He had that workout the day before. He does have that small osteophyte off the tip of the olecranon. Triceps tear would be more acute. Elbow effusion is always a possibility. And then a septic olecranon bursa, I think, is the biggest concern that we all have.
Okay, so you tell the patient you have bursitis, and they give you that look like you have two heads. How do you explain bursitis to a patient?
I think that's one of the things I like to do patient education. So I kind of educate them that these bursa sacs are all these fluid-filled sacs of fluids. Most of the time they're located between the mobile structures, so between skin and bone, between bone and tendon, between bone and ligament, and some between tendon and tendon. And they typically just allow the decreased friction to the area. So the lubricating fluid that's in there reduces the friction between those two structures. We have upwards of 150 different bursas throughout the body, but the olecranon bursa is the most common one we see that people come in with these fluid collections in it.
And so, of course, like you said, the worry is septic bursitis. Don't want to miss that. And can you please tell our listeners, I get these olecranon bursas that are red, they have edema in their forearm, they have redness spreading down the forearm and everything, and you look at it and the bursa is not all that boggy. So our upper extremity docs are really big on recognizing this aseptic bursitis and treating it, but if you have a septic bursitis, what's the difference? How are you going to know if it's aseptic or not? And, obviously some labs, but what are some clinical signs? What do you look for?
Yeah, that's a difficult one. I think that's the most common reason we get these referred to the orthopedic clinic from, primary cares or urgent cares is nobody wants to aspirate it in a, different setting concerning for the infection. It's hard to differentiate. I think definitely some of the big things to look out for, any overlying, redness of the skin. So obviously any erythema of the skin. Any overlying wound is important, fevers or any systemic symptoms. And then I think most commonly I see with septic bursitis is pain with range of motion. So those are the different clinical features that spike up in my head as kind of red flag features. Unfortunately, because of the superficial nature of the olecranon bursa and the fact that it has limited vascularity, it is definitely predisposed to get this septic bursitis. And a lot of the times this is just transcutaneous. It's not even hematogenous spread. And most of the time when I see it, I don't even see a wound over the elbow. It's just this red, swollen olecranon bursa, or like you said, you could even have this kind of swelling diffusely throughout the forearm and kind of the distal humeral area, and maybe not even going into the bursa. And that oftentimes could just be an overlying cellulitis with a olecranon or bursitis underneath it as well.
do you try to aspirate these in, if they're red, hot, swollen? Do you try to get some fluid off, or do you just do empiric treatments? Like, we're going to manage this conservatively with bracing pads, antibiotics. How do you manage these folks?
If somebody comes in and they have systemic symptoms, so they have fever and they have pain with range of motion, I probably will aspirate that because that's a concern of severe bursitis that potentially needs a washout. If somebody comes in and has that red kind of diffuse erythema, maybe some subcutaneous edema, some fluid collection within the bursal sac, but doesn't have any systemic symptoms, I won't aspirate them because if there's no infection in the bursal sac and it's all a superficial cellulitis, I don't want to introduce an infection into the bursal sac. Especially being at poor vascularity, I can easily introduce an infection from the skin into that area, no matter how sterile I am with my prep. And so I usually won't aspirate those. I'll treat those empirically on antibiotics, knowing that Staph aureus and beta hemolytic strep are the most common causes of this. I'll empirically treat them on antibiotics. I'll have them return to clinic in 5 to 7 days. If at that point the skin is improved and I can go through a non-erythematous skin to get into the bursa sac, then I may aspirate it at that time. That's my standard of care, at least.
Gotcha. I mentioned this in our discussion ahead of time that having OT nearby was actually kind of nice because you can make a custom anterior splint. I mean, you can make that with orthoblast or plaster or whatever, but having OT make a nice splint is helpful. And I could usually get people to wear it for about a week. And that's about how long it takes to get it to calm down. Because if they keep moving their elbow, they're going to keep aggravating it. So you have to kind of put it at rest. But imagine having your elbow locked straight for a week, and you can see why they don't last very long, but it does work. And then you had also mentioned some pads. We have these things called heel bow pads. They use them in, nursing facilities, skilled nursing to prevent decubitus and heels and elbows. So yeah, would you use any of that kind of stuff? And then antibiotics, if we're treating empirically, what would be your go-to antibiotic for that?
Regarding the pads and stuff, I think if somebody comes in, and obviously the most common reasons for this is typically some type of trauma. So I hit my elbow on something or I rest my elbow on something. We see this in a lot of truck drivers, a lot of students, a lot of people that kind of commonly just, rest and put their weight throughout their elbow and or repetitive motion, as you said. And so if we think that's the case, then I'll definitely try to treat this conservatively, especially if it's non-infectious. And I'll put them in some kind of compressive wrap, some splint, and definitely oral medications, anti-inflammatory medications, and things like that. Staph aureus and beta hemolytic strep are the most common bacteria that kind of cause either these septic bursitis infections or overlying cellulitis infections. So typically I'll cover that with Keflex, kind of give me some, dual coverage. If I'm concerned that, and or the area has susceptibilities concerning for, MRSA type infections, I'll add the Bactrim or doxycycline to it. So most of the time Keflex, sometimes dual coverage with Keflex and doxycycline because susceptibilities in my area show that has the highest success rate. And or if I think it's just staph oriented, the doxy or the Bactrim for the single coverage, antibiotic wise.
You had mentioned the use of injections, corticosteroid injections. Can you talk a little bit about that? I haven't used it for this. I haven't used it for ganglion cyst, but I know that it's acceptable to do. What is your thoughts on injections for this?
I think the more upper extremity people you work with, the more divisive it is whether you should inject these bursa sacs or not inject them. I think the most common thing is to not inject them, because of this concern of the avascular nature and the concern of possibly introducing infection into the area. Try to treat it conservatively. And if we can't get it better conservatively, then maybe consider the injection, but have that shared decision-making discussion with the patient. So most people that come in with these acute fluid collections within the elbow, I typically won't inject. I'll make them fail conservative treatment before I inject them, unless they insist on an injection or they've had one in the past and it worked well. If they come in chronically, with a lot of these come in 4-6 weeks after the fact saying, I've had this here and just won't go away. And it's becoming problemsome to them. They keep bumping it or hitting it or the skin overlying is, getting abrasive. Then I will potentially aspirate and inject those. When I do inject them, I use kind of the smaller crystal corticosteroids. So usually betamethasone, celestone, things like that. That'll reduce the risk of the side effects, including the hypopigmentation and the skin atrophy to the area. Or if you don't have it, you can use the depomedrol or the trimethanolone. But if you have access to those betamethasone, I think that's better for these superficial areas to reduce those side effects. And then usually I'll put some kind of a compressive dressing on there. I'll ask them to leave that on for 48 to 72 hours. So an ACE wrap with like 2 or 3 4x4s, and I'll have them leave that on as long as we can to reduce the reaccumulation of fluid in the area.
Yeah, I agree with you. If you're going to use cortisone for this, I would use just a little whiff. I wouldn't use a big dose. And I kind of think of these like the prepatellar bursitis. You can do serial aspirations with a compression wrap and all that. A sports med guy I worked with would have you do, I don't know, maybe 2 or 3 aspirations, try the splint, do all the other stuff. And if it kept persisting after that, he would talk to them about a bursectomy. And then, they also need to know you have the bursectomy, your elbow is going to be swollen for another 2 to 3 months. So just you want. And that's kind of the end point. That's kind of how we got to it. So, Chuck, do you have anything else to talk about with Olecranon bursitis?
No, I think that's it. I think, like I said, the big take-home points is a lot of the times if you see this in your clinic, try to treat it conservatively first before you refer to orthopedics, or if you're in orthopedics, try to treat it conservatively. If it doesn't get better with these conservative treatments that we talked about, then you can aspirate it. If you're not comfortable, you can send it for aspiration. Similarly on this, if I get that normal appearing fluid out of it, I won't send it for an analysis, but if it becomes this concerning fluid or a thicker fluid, I'll definitely send it. And then if there's any overlying redness or concern for an infection, I definitely don't think there's a side effect to giving them the empiric antibiotics to treat them and see if you can, resolve that, unless they're having systemic symptoms and we have to be more aggressive with it. So I think just watch out for all that.
All right, perfect. Great case study. And Chuck, thanks for being back on the podcast.
Yeah, thanks for having me.
Thank you for joining the orthoPAC podcast. Please follow the Physician Assistants in Orthopedic Surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.